So thank you to Oldways and to Walter Willett and David Katz for organizing this and for inviting me. Even though I left Harvard, they didn't forget about me completely, so that's great. I'm joking, of course. We remain good friends. And so I'm pleased to talk more broadly when we just realized that we had a little bit more time to talk about, the timer seems to be off by 3 minutes, but I will.
She said 20 to 25, so I said it at 20.
Okay. I'm going to talk broadly about evidence-based dietary policies. In terms of disclosures, I didn't know if we should report these. Previous speakers haven't, but I've received all of my research support from the Gates Foundation and NIH. I've done some ad hoc consulting. So I think we've all talked about this. This is just one more example I'll go over quickly. Diet is the single leading health issue of our time, also, as others have said, the single leading environmental issue of our time. This is a list of the annual deaths in the United States due to different causes. Dietary risks are now exceeding tobacco as the #1 cause of death in the United States. This is true for almost every country and every region in the world. So this is really the leading health issue of our time. And what's nice about this, at the same time this is becoming an incredible problem, there's been an explosion of science in both the nutrition side and the policy side. And so this is a graph of just publications you find, the count of publications you find if you put in these search terms in PubMed for different decades, the decades of the 80s, decades of the 90s, the 2000s. And what's really remarkable here is purple is just the first 4 years of this decade, actually, not even the whole decade. So there's been a real explosion of science. So what I tell people when they ask me what's going on with nutrition science, why does it always change? I say, nutrition science itself is a pretty young science, and nutrition science for chronic diseases, obesity, diabetes, cancers, cardiovascular diseases, even younger, maybe 30 years, 35 years old at most, robustly. And so we're learning a lot. And so I think that we should be very gratified by the changes and by the improvements in the science. So if we want to have effective policy, the first thing we need to know before we even pick a policy is what's the right dietary target. And right now, our dietary targets are heavily, our policy targets are heavily focused on calories and fat. In the 80s and 90s, everybody was thinking about heart disease, and everything was colored by a focus on LDL cholesterol. So everything was about fat and dietary cholesterol and saturated fat. Now everybody's so worried about obesity, everybody's talking about calories as if that's the only thing that matters. And in this room, of course, we're a very informed audience, and maybe we don't think this way, but if you really go out into the public for the communicators that are out here, this is still the focus, and this is still the policy focus. So the current 2010 dietary guidelines, throughout, there's extensive focus on portion size, calorie control, low-fat, lean choices. Obamacare mandated total calorie labeling on restaurant menus nationwide. At first glance, that makes sense. Well, yeah, we should know the number of calories in our food, but the explicit message there is that you can judge the healthfulness of the meal based on its calories, and I think that's totally false. 800 calories of healthy food is better for you than 600 calories of bad food, including for obesity. But that's the explicit message of a menu label that has total calories on it. The US front of pack, the UK front of pack, total calories and total fat are the first two items on their traffic light. The US FDA, as many people have seen, their new proposed label has much greater emphasis on calories. And the US FDA also continues to have decades-old guidelines that limit healthy claims about foods based on fat content. So Kind bars, which is the only thing I can buy in an airport, when I'm traveling, which are nuts and fruit and cocoa, got a violation letter this March because they had too much fat and saturated fat in their bars, even though all of it's from nuts. The National School Lunch Program has many positive changes, but among these, the negative changes were they banned whole milk, but allow sugar-sweetened skim milk because of a focus on fat, saturated fat, and calories. And I'll show you the NIH dietary guidelines for kids. Here they are on the NIH website. If you look what the National Heart, Lung, and Blood Institute is recommending to families with kids, this is their Go Slow, Whoa program. Go foods, eat almost any time. Slow, eat sometimes. Whoa, eat once in a while. In the Go foods, they have trimmed beef and pork. If you just cut the fat, then eat all the beef and pork you want. Fat-free salad dressing, fat-free mayonnaise, and diet soda. And when I saw this years ago now, I had to go to the supermarket to look and see what is in fat-free salad dressing, right? It's salad dressing, right? So if it's fat-free, what is it? It's just starch, salt, and sugar. And then, so that's eat almost any time. And then, be careful, once in a while, all vegetables with added fat. Notice the absence of any qualifiers as opposed to the science that Frank Hu just presented, all vegetables with added fat, avocados, tuna canned in oil. And tuna canned in oil, it's usually soybean or olive oil, both really healthy oils, peanut butter, nuts, vegetable oil, olive oil, all incredibly healthy things for people to be careful about. They're in the same category as low-fat hot dogs, ginger snaps, pretzels, oven-baked French fries, and sports drinks. And then the raw foods include whole eggs cooked with fat, again, no qualifiers, and whole milk are in the same category as cookies, cakes, and soda. So, these scientists are well-meaning, they're very smart, they're very informed, and you can see this is the actual still NHLBI guidelines out there for diet. You can see what happens when you have this focus on calories and fat. I think David Ludwig and others covered this earlier today. In terms of obesity, it's not about calories, I think. I think calories is the wrong focus. All calories are not the same because foods have very different influences on our physiology. And I think, talking about marketing, this leads to all kinds of, misleading marketing by the food industry. So baked potato chips are a healthier choice because they're lower in calories. Well, in fact, the only ingredient that's been removed is healthy vegetable oil, soybean oil or canola oil, which is good for you, leaving more starch and salt. So it's actually a much worse choice. Turkey sausages as being a healthier choice than beef sausages because they're lower in fat, fat-free salad dressing. 100-calorie snack bars, as though it's better to eat 100 calories of junk rather than 200 calories of nuts or something good. And if anybody did anybody read Michael Moss's book, Fat, Sugar, and Salt? So, that was an excellent book for its focus on the incredible advances in marketing technology that have happened over the last 30 years. But what was amazing to me is that book didn't quite get its own hypothesis. So the hypothesis of the book was it's all about the nutrients, the fat, sugar, and the salt. But really what Michael Moss showed really eloquently is in every case, the products that succeeded or failed didn't change their fat, sugar, or salt. They changed their marketing. They changed their promotion. They changed what they were associated with. Coke is no sweeter. It has no more sugar than any other soda, but it dominates the market because of its marketing. Lunchables was a great example how they had all of these different products that were failing, and they put them together in a new fun package for kids, and now Lunchables is a huge multi-billion-dollar industry. They didn't change the fat, sugar, or salt. So there's a lot of great things in there about the incredible advances in marketing, and I think that's really important. So the last thing I want to say about diet priorities before we move on is the reason I think I really worry about the focus on obesity. Obesity, of course, is important, but it's one thing, right? It's one thing among all the pathways that diet affects our health. It's one thing. It's a minority of the pathways, actually. It's visible. We see it. We worry about it, but it's not all of diet. So diet affects almost every risk factor and pathway you can think of that affects your brain health, your heart health, your metabolic health, your energy, your muscle health, your healthy aging, and so on. So we need to move beyond this. So I think Frank Hu summarized this nicely, and this is a huge advance for the Dietary Guidelines Advisory Committee report, is it's really we have to move on to food patterns, and it's about foods. And this is sort of my own list based on the evidence of what I think where our policy priorities should focus, mostly on foods with a couple of exceptions, sodium and trans fat because they're additives. We should be minimizing refined grains, starches, and sugars, processed meats, industrial trans fat. There's foods that are kind of in the middle. Unprocessed red meat likely raises the risk of diabetes modestly because of heme iron and maybe some other components. Eggs, poultry, milk seem a little bit neutral, maybe a little bit good for you. Cheese, I put in there, I think, could be actually linked to lower risk of diabetes, pretty neutral for heart disease. And then there's foods that are really beneficial that we all agree on. So the common ground, I think, is at the top of this list. So the public doesn't get this. So how do we get, through policy, the public to move toward these healthy choices? This is the current food landscape that all of our media experts in the room live every day. This is what people are talking about, right? This is what's driving public choices today. This is what's driving industry change. So there's a great article in the New York Times, I don't know if maybe somebody here wrote it, there's a great article in the New York Times just a couple of weeks ago about the what do they call it, the huge change that's going on in the food industry. Food industry is really changing, but it's about this. Right, they're changing to develop clean labels and be gluten-free and be natural and be organic and be local and be paleo and be low carb. And so I think that most of this isn't really strongly evidence-based yet. I mean, these are fads and ideas. Gluten-free, of course, is important for people who have gluten sensitivity and may be important for others, but as a single metric for identifying healthfulness, it's not very useful. The main thing probably on here that's most important for identifying healthfulness is Mediterranean. That's a reasonable fad, I think, and Oldways has been you know, one of the main supporters of that fad. The reason I don't circle vegetarian and vegan as being important by itself, people have mentioned that a few times. You know, French fries and Coca-Cola are vegetarian and vegan. Sodium is vegetarian and vegan. Trans fat is vegetarian and vegan. So just being vegetarian and vegan doesn't give you any guarantee of having a healthful diet. You can have a terrible diet and be a vegetarian, and you can have a very good diet and not be a vegetarian. So I think explicitly on a scientific basis, vegetarianism per se is not actually the right concept. So if we want to change behavior through policy, we can do it one person at a time, and this is kind of what's supposed to be done in the healthcare system, but doctors don't usually learn much about this. There are Class 1A recommendations for behavior change in the clinic, and you can do these things. And what's interesting is that a lot of these approaches, setting targeted shared goals, self-monitoring, feedback, plan follow-up, peer support, this is what a lot of the apps are doing, right? This is what a lot of the novel technologies are doing today, and I'll mention that in a little bit again. So I think what's most promising about this is we've learned sort of behavioral theory in the clinic, one person at a time. It's pretty inefficient, it's pretty inexpensive, it should still be done. But if we can take this and expand it to novel technologies, I think that's really where there's potential. But I think really in terms of the health system, rather than going one patient at a time, we need to change the health system. We need to change the health system to address lifestyle. And these are the kind of the things that I think are probably most important. First, we have to educate the providers. We have to educate the doctors, the nurse practitioners, the nurses, and the dietitians that we're doing on lifestyle and behavior change. And I'm a physician, I'm a cardiologist, and I didn't learn almost anything about nutrition in medical school or internal medicine or cardiology or behavior change. And prior to going to Tufts, I saw patients at Brigham Women's Hospital, arguably the top, if not one of the top academic hospitals in the country. And the internal medicine residents and the cardiology fellows there, among the smartest doctors in the world, had no idea about nutrition. They didn't even know the grams of calories in protein, carb versus fat when I talked to them. They know less than the average person on the street knows because they're so deep in the technology of modern medicine. So education is clearly important. And actually, I was in a trip in the Netherlands, and in a conversation got me to think about this. If we actually wanted to change the educational system, all we have to do is change the boards, change the USMLE. If we go to the US medical licensing exam, and we say 10% of questions on the board should be about lifestyle, nutrition, if you change the boards, every medical school curriculum will change. So it's a single step, and it could change medical education overnight. In a year. I don't want to be prone to hyperbole. We need to change the electronic health record, and there's a huge opportunity here. I think we just missed the first revision, but the Affordable Care Act has provisions for penalties if you don't have a good electronic health record, and for bonuses in terms of payments if you do. And I think they just came out with after public comment, the first round, but there's going to be other rounds. We should collectively demand that the electronic health record include diet, right? How can the number one cause of poor health in the country not be in the electronic health record, right? I mean, the irony of that is profound, right? So obesity now has to be in it, smoking has to be in it, physical activity and diet must be mandated to be in the electronic health record. We need to have regular follow-up, we need to have regular feedback, we need to have peer support. Those things can be built into systems. And then again, importantly, we should build standards and reimbursement guidelines. That's what drives the health system in the end, that focus on health behaviors, diet quality, and physical activity. This is already done, for example, post-MI. If a hospital doesn't, post-heart attack, after a heart attack, if a hospital doesn't give smoking cessation counseling to smokers, they lose quality benchmarks and they might even lose reimbursement. So we should be able to do this for diet and physical activity. And there's another wonderful potential provision in the Affordable Care Act about accountable care organizations. So have people heard about the accountable care organizations? 50% of all dollars through the Affordable Care Act, I think by 2020, have to be paid through accountable care organizations, where the hospitals or doctors' networks get bonuses if they improve the health of the community, and they lose those bonuses, or they even get dinged if they don't improve the health of the community. And so this is brand new. This is sort of fine print in the Affordable Care Act that's actually now being implemented. And hospitals everywhere are starting to wonder, well, we have to become community prevention organizations. So this could have huge potential impact. But at the end of the day, I think one of the panelists said this best. I think this idea that it's all about individual choice and the health system and giving us just, telling us that we can eat what we want, I think is mostly an illusion. I think that there are so many influences on our choices. Even here, we're the top 0.1% of 0.1% of 0.1% of the world in terms of our food choices. Whatever you ate today was pretty much limited to the selection that you had around you today. And there are individual influences on choice, but they include not just our income and our education, but our health status, our eating behaviors, our motivation, our sleep, our screen time. And then there's many social-cultural influences around that, many community environment influences around that, many agricultural influences, government influences, and global influences. And so, I think in America, in particular, Europe less so, we've had an aversion to robust dietary policies because we're sort of, individual rugged cowboys. It's, don't tread on me, right? It's all about free choice, but it's really not about free choice. And so I think these are all challenges and barriers, but these are all levers. And so I think we should view all of these things as levers to improve the food system. So across the policy domains, the things we could do, I think sort of fall into these broad categories: media and education, labeling and information on products or on menus, interventions in schools or in workplaces, changing the local built environment, like the locations of grocery stores and fast food restaurants and so forth, economic incentives either to retailers, producers, or the consumer, quality standards, and I've changed my lingo on this in the last few months. I used to say restrictions, right? Like people say the trans fat ban. It's really a quality standard, right? That's really what it is. So we have quality standards for cars, we have quality standards for buildings, we have quality standards for most things. We should have quality standards for food. And then our agricultural policies. So I think based on our review of the evidence, and this is ongoing with funding from a Gates Foundation grant and 2 NIH grants, these are the most promising dietary policy priorities we could have. This is one paper we published a few years ago, but we have ongoing unpublished work looking at this. So, and I'll mention a little bit more, but I think economic incentives clearly work, and they work best in lower income people who are most at risk. And so I think we could create a national, or start with states, tax subsidy framework to reflect the real costs of food. A second huge priority is to create strong health-aligned standards and incentives in food assistance programs, and SNAP is the obvious choice, and Walter Willett has written about this. Eric Rim has done some work based in SNAP. SNAP is really an incredible opportunity, the food stamps program, to change the food supply, because about 35 million Americans are on SNAP, but there's probably 50 million more Americans in their neighborhoods. And so that's about 80 million Americans. All of those Americans would be influenced if we altered what SNAP would pay for. So what do people think is the number one food or item bought by food stamps in this country? Cigarettes can't be bought, so there is a restriction on that. But it's soda, right? And how many servings per day of soda are purchased by SNAP? Anybody? In the country, how many servings per day are purchased by SNAP? 60 million, right? 60 million servings per day of soda. There's 35 million people. They have almost 2 servings per day on average, right? And we're paying for that with our taxes. So that's right. So this is an obvious low-hanging fruit for changing this. And there are people at USDA that realize this and want to do it. So this is a definite potential. I think we should have strong industry incentives and disincentives to develop and market healthier foods. The government can do that. They can give them strong research incentives, marketing incentives, tax breaks to develop healthier foods, and disincentives if they don't do so. Schools and workplaces are really an effective place to reach people if you have comprehensive programs. Kids spend a lot of their time at school, adults spend a lot of their time at work. And so 3 things that work that we've reviewed and we're submitting papers on are, so first, if you really have comprehensive multi-component wellness programs, that works, right? If you address policy, education, peer support, the environment, that works. If you just have a class, or you just have education, or you just do one thing, it doesn't do so well. But a comprehensive program clearly works. School procurement policies to mandate purchases of healthier foods like local fruits and vegetables or other things, that works. That significantly improves intake in kids. So that's been shown in a meta-analysis that we've recently finished to increase intake of healthier foods. And then quality standards on competitive foods and beverages. Competitive foods are things outside the paid lunch system. That also works to reduce intake of unhealthy foods. Quality standards on additives, salt and trans fat being, I think, the most obvious ones. That works as well, and that should be done, and that has been implemented in many countries and states. And then quality standards, again, not restrictions, but quality standards on marketing to children, I think are important. We actually found remarkably little empiric evidence that that works. Basically, all the evidence is through inference that we know how powerful marketing is to kids, and we know most of the marketing they see is for bad foods. There's been almost no studies of this, trials or even observational studies, because very few places have marketing restrictions. Interestingly, there are a lot of them in Europe, marketing restrictions to children, but those haven't been evaluated in terms of their impact. But through first principles, we think that those things work. Other policies, to complete the list, really long-term policies over decades that are for production, storage, transport, and sales of healthier foods. Those work. Harmonization of policies and priorities across federal agencies. USDA, Health and Human Services, CDC, and FDA have totally different dietary guidelines and policies and priorities. Those should be harmonized. And something that's worked really well in other countries is I think the government should have a standing National Nutrition Advisory Board. That works very well. Rather than the Dietary Guidelines Advisory Committee, which is for one thing, it's formed and disbanded, they should have a standing committee so when senators and congressmen want science, which is not always the case, they have somebody to go to and get standing advice. So just really briefly, examples of strategies with less evidence to just show you, and these are sort of the evidence scales. Many of these are just kind of knowledge alone. So we actually found pretty good evidence that nutrition facts panels, front of pack labels, menu labeling doesn't actually influence consumer behavior on average. There are individuals who might be influenced by it, but it doesn't work. Just school-based education alone, just promoting water use alone, just putting cafeteria vending labels or prompts alone doesn't have a big impact. So knowledge alone is helpful, but it doesn't change behavior. The other things that I want to focus on is built environment. There's a lot of talk about food deserts and built environment and so forth. There's actually not great evidence that that actually influences intake. It sort of makes sense that it would on first principles, but it's mostly cross-sectional. It's not, the cross-sectional evidence is most consistent for availability of supermarkets. But in a cross-sectional study, it's unclear if the supermarket's not there because that population doesn't buy the food, or if that population can't buy the food because the supermarket's not there. And in prospective longitudinal studies that have been done looking at supermarkets being introduced or people moving, there actually hasn't been consistent relationships with better diets. The RAND Corporation just